always due to bacterial infection. Early diagnosis is going to be key. So appropriately, sometimes the treatment is just antibiotics, whether it's PO or IV. Sometimes it's surgical debridement, depending on how involved it is. Sometimes you're going to be, talking to everybody. So you're going to talk to your supervising physician, you're going to talk to the orthopedist, you're going to talk to the infectious disease. If they are going to need surgical intervention, then obviously you're going to bring in ortho as well, depending on where it's at. If it's around the face, then it might be plastics or even other places, depending on how ugly and how significantly severe it is. If it's deformity, those kinds of things. All right. Classifications of osteomyelitis, there's 3. It all goes off of timing. These are the questions you're going to ask. How long have they had it? What was the mechanism of injury? What caused this injury? And then 3, the type of the host response. So what was that person's body's response to this? Timing. So we're talking acute, subacute, or chronic. Acute is anything less than 2 weeks. Subacute is 2 to 6 weeks. And then chronic greater than 6 weeks. Mechanism of injury. Is it within the body or outside of the body? So exogenous, it occurred, something from the outside entered and caused this infection, or 2, it originated from inside the body itself. Type of host response. So did they develop pus? Did they not? Pus, obviously, an inoculation is, by definition, an abscess. Not all pus causes abscesses. But in the absence of an abscess or pus itself, then it's non-pyogenic. So we've got the terms now. So again, the term of what the diagnosis: acute hematogenous osteomyelitis. This means acute, less than 2 weeks. Hematogenous, it was from within the body, being the blood. And osteomyelitis, the infection is bone. So, most common type of bone infection is more common in infants and children. It occurs in the long bones metastasis following the seeding by the bacteria itself, meaning it got into their bloodstream. Bacteria. So the distribution of the ages that this affects is bimodal. It can be less than 2 years of age or 8 to 12 years of age, which a lot of us don't think that's going to be a common age for osteomyelitis. There's an explanation for that that's easily understood. As far as more common in males, not as easily understood. Not always do we have more males than females in the population. I don't know if it's because they have more fractures or more injuries. I don't know what the reason behind that is, but just know it's more common in males. In adults, the vertebrae are the most common site, followed by the long bones, pelvis, and the clavicle, which kind of goes along with erythropoiesis, which we just discussed. Okay. Long bones being the femur, humerus, pelvis, and then the clavicle. All right, so I jumped way ahead. I probably need to put this in a different order. Discitis. Osteomyelitis means bone, right? Osteo, bone. Infection. Myelo is anything soft tissue of the myelinated areas. So you've got your brain and your spinal cord that are surrounded. So discs, obviously, are very, very close to the spinal cord, in between both of your vertebrae. This picture mainly is going to help you to know when I'm looking for an osteomyelitis of the spine, as well as discitis. One, on physical examination, you're going to have midline tenderness to palpation It's not only going to be on the posterior processes, which are the bony processes that you can palpate, but also in between, which is where you're the space, which is where your discs are going to be. So when you're trying to determine and figure out and palpate for your LP, and you have a patient that's exquisitely tender, it almost comes off the table, then you need to be thinking discitis. Before you do that lumbar puncture, you don't want to be putting a needle in that until you know exactly where that infection is. Is it in the spinal canal? Is it in the disc? Is it in the bone? So let's stop for a second, don't do the LP, and let's move to do an MRI or CT. The best to differentiate, if you're thinking osteo, bone, and they haven't recently had a surgical procedure, then do the CT. If they have, then it could be bone or soft tissue, because all of that was manipulated during the surgical procedure, and we're going to do both the MRI that you can see bone and soft tissue. Contrast obviously is going to just enable you to see better what's going on. The images here are showing the difference between sagittal T1 and sagittal T2 is the weighted of your imaging during radiology settings. But this one also shows you with and without contrast. So the sagittal T2, and that's the other reason why I labeled it that way, is so that you can differentiate which one had the contrast. T2 has the contrast in it. So the lighting up in between, and you will count. Lumbar spine is counted from the bottom, unless you're skilled enough to know the anatomy, and you can see the complete thoracic. The thoracic that stops the ribs coming off is when you start your lumbar spine counting, but it's easier to start from the bottom. So you've got your sacrum, which is the part that's scrunched together, L5, 4, 3. So that disc there is S1, L5, 4, 3. 5, 4, 3, 2. So it's the disc between L2 and L3. So your discs are named by the bone above and below it. So that's named L2-3 disc. You're never going to see an L2 disc or an L4 disc because you don't know whether it's above or below that L level. Okay? You're always going to have two numbers. But that just shows you the difference between, we can tell that the sagittal T1's messed up, what the heck is that? But it's even better and more clear that it's the disc itself, because the bone the bone is the darker, and the disc material is down below, is lighter. But that whole whited area that's blown out is actually within the bone itself, not within the disc. So I said that wrong. That's in the bone itself. It's not coming from the spinal canal because you can see the spinal canal. Do you guys understand the anatomy there? Mm-hmm. Okay, the spinal canal has a definitive stop and is not connected to that contrast that's blown out there. Okay. So that's going to be how you would differentiate whether it's a discitis or osteomyelitis. If you're suspecting with a discitis but you don't know the etiology of the organism, because that can be a very, very nasty organism and can make them sick and can be lethal if you don't get the correct diagnosis and get them on the right antibiotic, then you're going to do a biopsy. And that, again, is done by interventional radiology. So they'll go in and take a chunk out of that disc and do cultures and sensitivity on that, and then you'll have your definitive. Obviously, for anything that's significant, you're going to have your empirical first treatment, and then you're going to go beyond that. All right. So, acute hematogenous osteomyelitis, the bacterial seeding of the bone, associated with factors such as localized trauma, chronic illness, malnutrition, and an inadequate immune system. So trauma, number one, somebody that was in a car accident doesn't necessarily mean that they had fractured, but they may have a disc that is bulging or even ruptured. Then you've got an open area that's inflamed. And again, that's bled into that area, and a hematoma and blood and moisture, bacterial lead. So if you've gotten an infection, it's going to go to that area possibly. Not real common, but it is. The most times that I've encountered discitis, and it was probably skewed because I did neurology, neurosurgery, were the people post-operatively. Those are the things that you're monitoring for. But when you have a patient that comes in with back pain and they just recently had a surgical procedure, that's the first thing you need to make sure that you rule out. Is if they don't have an osteomyelitis or a discitis secondary to that surgical procedure, having an inoculation of an infection. Chronic illness, again, somebody that's chronically ill all the time, their immune system just isn't as good, so it's not going to fight off, and so they're going to be more probable of getting these bad illnesses or bad infections. Malnutrition, because they don't have the nutrients to fight off bacterial infections, and then obviously that leads to a decreased immune system, and people that have an inadequate immune system are going to have more problems with an endogenous or hematogenous osteomyelitis. Pathophysiology, again, we've already talked about children, so it's the metaphysis that's involved. This is the area that's highly vascular. Again, blood feeds bacteria. Hematogenous, it arises in the bloodstream, and so therefore it goes to those rapidly growing long bones. Then that causes an inflammatory reaction in that area of that bone, causes a localized necrosis. So you start having that bacteria eating away at the bone. And it's going to look like that on your plain film x-rays as well as your CT or MRI. You could or could not have subsequent bone abscess formation. So again, pyogenic would be a description used with that one if there is an abscess being formed. And then you've got the intramedullary pressure. So this is where your bone anatomy comes in, and knowing where your epiphysis, physis, metaphysis, all of those things are again. So not only does that do you well for Salter-Harris fractures, but for types of osteomyelitis and the age groups. Because you're going to need to explain these area involved to the specialist that you call on the phone. All right. So the intramedullary pressure increases when you've got an abscess that's within the bone. That abscess continues to push and grow, causing surrounding ischemia and destruction of the bone around it. Once it goes outside the cortex, which is the periphery, your border, your cortical border. So when I'm describing bones on an x-ray, there's no cortical disruption. Or I see a cortical irregularity that's suspicious of a fracture, acute fracture. Or I see a non-linear cortical deformity, not really indicative yet of an osteomyelitis because it's not eaten away yet or destroyed, but it's bulging. What's causing that? Those are the things that you're going to communicate with your specialist. These are the terms that the radiologist is going to describe these bone structures to you in your report. Learn from those reports. When you go out on rotations, read the difference out of those radiology reports, and if you don't understand them, ask your preceptor or go to the radiologist, because a lot of these rural towns love to teach, and the radiologist will spend time with you. Find out when they do their reads and go during those hours, and you'll learn a lot. That's how I learned most of my radiology and ended up with an interventional radiology position at one point in time. Just because of the amount of time that I spent with it. All right. If you have this occurring with an infection, obviously within the bone, and it's left untreated, then that becomes more extensive, and you have a sequestration, which is almost like a chronic hardened bone around the abscess. Because again, your body walls off pus, forming an abscess to protect the body. The bone will also develop calcium deposits, just like it does for repairing a fracture, to repair that lytic or necrotic bone that's there. And so then it's going to make it thicker. And then you end up with a part of that kind of floating in there, that infection just floating within the middle of the bone. The sequestrum, you can actually have like a tract, like a river within the bone that's leading, almost like a tract of an abscess that eventually, if it's superficial enough, will start erupting and come out. Same thing with the bone. It's going to try and find a tract to drain. As far as a infection that has sequestrum and walled off, it doesn't get as much circulation. So if it doesn't have the vascularity within that area of the bone because it's walled it off by those calcium deposits, then the antibiotic that you're putting in your mouth that's in their bloodstream is not going to get there and penetrate because it doesn't have blood supply, right? So therefore it's going to require more than just antibiotics. Those are the ones that cause, you need to call them orthopedists because they're going to surgically need to have that excised, scraped, cut out. All right, here's your pictures. So the terms that I talked about earlier, the involucrum is a complication of the osteomyelitis that develops prior to the formation of a sequestrum. Okay. The sequestrum over on the right-hand side is almost like that walled-off area and starting to make a little bit of a tract. And you see the middle aspect of the bone is looking to be less dense or darker. Okay. Again, the pathophysiology of why it occurs mostly in children less than 2 years of age, their growth plates are still open. They still have tons of blood vessels across the physis, and then therefore the epiphysis is involved. When they have a problem with an infection, it's going to cause their growth plates to be affected, just like a fracture within the growth plate, and then it's not going to grow right. So you're going to have limb shortening, angular deformities going on. And that, again, is where you're possibly going to need plastics come in. Contiguous joints may be involved. So your hip joint is the most common, because you've got your intra-articular space. The proximal humerus is your next most common. Then your radial neck, which is right below the radial head, sorry. Grabbed my humerus. And then you've got your distal fibula. Metaphyses have fewer phagocytic cells than physes and diaphysis because of the blood supply. Again, the vascularity is not as great. So that is one of the, that is not, I guess that's the radial neck below the distal radius, not the proximal radius. Children that are older than 2 years. So the other group that we were talking about, 8 to 14, 8 to 12, sorry. Just have to think of their anatomy. Again, they still have their growth plates that are open. They don't close until you reach puberty. Females faster than males. Maybe that's why males are greater affected as well. Physis is affected acts as a barrier to the spread of a metaphyseal abscess. And then that metaphyseal cortex is always thicker. And so therefore the diaphysis is at more risk in that age group. Keys that I would know is, what is the age group that's being affected? Where is it more likely going to be? And then understanding why, because of the anatomy of those bones. The vascularity of it versus the lesser of the vascularity. after the physes are closed, which is your growth plates, the infection can extend directly from the metaphysis to the epiphysis and involve the joint. That's why we see more septic arthritis in our adolescents that are greater than 12 years of age. But they are also the ones that are sexually active, and that's the most common cause of the septic arthritis, is your STD. So, which is contraindicated by the next statement. Septic arthritis resulting from an acute hematogenous osteomyelitis is seen only in infants and adults. So, evidently, that is opposite of what I just said. Obviously, you won't get a question on that. Now I'm confused. Love medicine. All right, histology and microbiology. Staph aureus, Staph aureus, Staph aureus, Staph aureus. If you don't know what the organism is, it's more likely going to be Staph aureus in osteomyelitis, regardless of the age group. So that makes it easy, right? You'll see a slide that I actually make of all of the age groups, and one of the most common Staph aureus is always the answer. Older children and adults, their negative bacteria is increasing due to the vertebral osteomyelitis, and again, those are going to be ones that have an injury of the spine itself or a surgical intervention in that area. Pseudomonas, most common in IV drug users, and that's with sepsis or osteomyelitis, so it's still the same answer. That's nothing new to you. Sickle cell disease has to do with their anatomy and their growth and their development because they're born with this, and so they already have a predisposition or a problem. So Salmonella is the organism that's most commonly going to cause their infection. Just have that memorized, bless you. Okay. Fungal infections, again, it's going to be your immunosuppressed patients or people that are on long-term IV antibiotics. There's your example again. Infants, premature neonates, it doesn't matter. Staph aureus, again, is the #1 causative agent. Haemophilus influenza used to be really, really big on the differential as far as the etiology, but it is no longer a top priority because of Haemophilus influenza B vaccinations. The reason that vaccinations are really, really important is it eradicates these problems. But if you practice in an area that doesn't do immunizations, or you have a high population that refuses immunizations, then that certainly needs to be in your differential. That's the only reason why this is still listed on this slide. Presenting symptoms: fever, malaise, pain in a localized tender area, swelling, and sometimes compartment syndrome. So you've got a child that's complaining of a limb that is hurting. They weren't born with a hip problem. They've been walking fine, but now all of a sudden they're not using it. Children are smart. If it hurts, they don't use it. There was no specific injury observed. That doesn't always mean that there wasn't, so you're going to x-ray it. X-rays may or may not give you an indication. X-rays sometimes are going to be normal. So that just shows to you that there's no fracture. You're going to watch them more closely, making sure there's no hairline fracture, but then the next thing on your differential is going to be osteomyelitis, and obviously, if they've got the fever and malaise, that's not always going to be there with just an acute fracture, unless it's a pelvis or multiple bones or femur. Hematogenous, again, we're thinking blood, so these are the labs you're going to be doing: CBC, elevated white count, elevated CRP, sed rate also. Again, those are broad. C-reactive protein, I highlighted it on this one. It's going to help you with the monitoring of the diagnosis and the diagnosis confirmation. So repeating it every 2 to 3 days after the initiation of antibiotics. So your CRP was elevated with infection and inflammation. You started them on antibiotics, it started to improve. CRP is going to start coming down. That is going to respond faster than your sed rate, and that's why sed rate is no longer used. before CRP existed and was found to be a good indicator. That was what we used, but it was a poor indicator. All right, aspiration of the abscess or the bone aspirate. If you've got a nodule or an abnormality noted on x-ray, you're going to biopsy that. Again, interventional radiology will do that. And then they will also grow that out for culture and sensitivity of the lab. Aerobic, anaerobic, fungal, and viral. Viral, I don't know how common that would be in the bone, but I would still order it. X-ray orders. So knowing, again, this is acute. So this is them coming in and complaining of these symptoms less than how many days? 2. All right. Plain films. Usually doesn't show up for 10 to 12 days, so expect those to be normal. That's just your regular x-ray of whatever it is. Bone scan. 24 to 48 hours after the onset of an infection, it is confirmatory in 90 to 95% of the cases, so that's pretty darn specific and sensitive. And again, this is the bone scan, not the CT, so it's not as much radiation, and you're specifically ordering it for whatever part of the body that they're complaining about. If it is the back, you're probably, instead of just plain film, lumbar spine, C-spine, you're going to get an MRI because we need to know, is it just the bone, is it soft tissue involvement, how significant is that? So that's when you're going to do your MRIs with and without contrast. Here's an x-ray of the plain film. See how it's kind of curved there, but you're starting to see that cortical disruption. You can still see the fine defined line of the right, well, it would be the patient's left side, but the right side of the picture. But you see all of that feathering out to the side as well, so that's disruption continuing to go on. Obviously, the middle of that shows a decreased density, and so almost like a cavity being developed. Again, we don't know if there's an abscess there or that's just a tract yet, but obviously you've got soft tissue swelling. So you're not only seeing the cortical bone and that featheriness, but if you were to change the density, which is awesome in radiology, you just take your mouse and change that to where you can literally see the soft tissue line as well, and there's going to be a lot of swelling. You're going to see soft tissue swelling before you see cortical disruption. So that's where your fat pat signs come in. That's really important to pay attention to your soft tissue. You're going to look at every 50 shades of gray on an x-ray or more. Again, bone destruction, 10 to 12 days. So this is a 10 to 12 day post at least, if not further along. Treatment, surgery, antibiotic therapy. Choice of antibiotics, again, it's going to just know what's your microbiology, what's the most known organism. Staph aureus. All right. NAIDS principles of treatment. This just tells you how aggressive to be and at what stage do you change that. So knowing the appropriate antibiotic before pus formation and getting on that, acting fast. Antibiotics will not sterilize or stop the growth or progression of an avascular tissue or an abscessed bone infection, especially in areas where they still have a growth plate because there's no circulation going to be in that area. So then it's going to require surgical debridement, which means you need to call an orthopedic surgeon, and then let them make the call on whether or not they need to get plastics involved. Again, depending on where you work, I worked rural, so I just called the orthopedic surgeon. He called the infectious disease because there's no reason for me to call, bringing them to my facility. They're going to be going elsewhere. So again, it all depends on where you're practicing. The removal is the most appropriate. So they're going to remove the bad tissue, remove the infection as much as possible, flush that out. They're going to be putting antibiotics IV intravenously during that procedure, but then they're also going to flush the area with an antibiotic solution lavage. And then surgery should not further damage the already ischemic bone. And again, that's just going to be up to the orthopedist on how extensive they want to be. Antibiotics obviously will be continued afterwards. Two main indications of surgery would be the presence of an abscess that you can't get to with an IV or a PO antibiotic, or failure of the patient to improve despite the appropriate IV antibiotics because you've gotten the identification of the organism, but they're still not responding. So then that would be the secondary reason for surgery. Two objectives. The main thing for surgery would be to get that infection out, drain the abscess, and then remove all bad tissue because it's not going to reverse itself. It's dead. Get it out. Dead tissue becomes food for bacteria. Here's another picture. So you've got a frontal view and an oblique view of a post-operative osteomyelitis. It's not ever going to go back to normal, but it's not going to continue to progress. Yes?
Are they at increased risk for fractures?
Absolutely, yeah, because it's obviously affecting the bone stability there. So you can tell, well, there's some type of apparatus on that because you can see the lines outside the soft tissue, which you can tell is not the patient's leg. So he's in some type of splint. See that? So definitely splint these people just like they were in a fracture because you want to prevent that from fracturing. You're obviously not going to cast it, especially if they're immediately going to surgery, but you're never going to cast an infection. You don't know when it's going to swell, when they're going to get worse, whether they're going to get better or get worse before they get better. Okay? And you don't want to be causing a compartment syndrome. That would be what you would be doing. Subacute. So again, timing. Subacute is between 2 and 6 weeks. I'm sorry, I said 2 days earlier. I meant 2 weeks for acute. Less than 2 weeks. 2 to 6 weeks is subacute. And again, the symptoms are the same, it's just not as severe. The course of the diagnosis, of course, has already been delayed for 2 weeks, so you need to make sure that you don't just discount this, and you make sure that it's in your differential so that you can pick up on it. Your bacteria are going to be stronger, so they're not going to be as virulent to those antibiotics because they've been actively mounting a army load before you've already started the antibiotics. Your host is also going to be more resistant because they're going to be not as symptomatic, but their immune system obviously kind of mediocre, not low enough to where they're not mounting a response, but also not heightened to where they're getting that inflammation red hot and a lot of pain. Physical examination, again, signs and symptoms are minimal, temperature is just mildly elevated, and their pain is mild or moderate. So just know that it's the same picture, just not as significant. Again, your white count, SED rate is only elevated in 50% of these patients. So if your SED rate and your CRP are elevated, then it's more likely going to be acute. If it is not elevated, it just means that it's not acute. It doesn't necessarily mean that it's not subacute osteomyelitis. Blood cultures are almost always negative, and then again, your x-rays are going to be the key because you're going to go, oh crap, we don't have an elevated white count. They really aren't symptomatic to make me think of osteomyelitis, but now our x-ray looks like it, so that just means it's a subacute case. Again, Staph aureus. Staph aureus, Staph aureus. A Brody abscess, again, is the one with the subacute osteomyelitis. Occurs mostly of the long bones and in the lower extremities. Duration lasts longer, that's why it's subacute, it's just less severe. You can see there in the distal tibia, where you've got a weird looking portion of the bone there centrally. Sometimes very difficult to diagnose, but they're going to be symptomatic and have a lot of pain. Plain films, sometimes it's a lytic lesion. That one is not showing a lytic lesion. It's just almost like an abscess within the bone. Rim of sclerotic bone, again, the growth plate still looks linear. It doesn't look disrupted at all to me. Oops, what's wrong? Staph aureus, again, answer. So we got that down. Biopsy for diagnosis, and then curettage, which is just that needle biopsy. It just grasps a piece of that. And then wound should be closely or loosely drained. Again, orthopedists are going to do that. I am not going to test you on Glen Hill classification. I'm going to write myself a note just in case there is one last year. But just know there's another classification other than just your Salter Harris fractures. Glen Hill is something that you need to know for your boards, so just make sure that you know this. For your board exam, all right? And again, knowing the anatomy, epiphysis, metaphysis, physis, all the age group, where it's at. We already talked about the treatment being biopsy and then aggressive antibiotics, and lesions that are a simple abscess, IV antibiotics for 48 hours followed by 6 weeks course of antibiotics. So if it just seems to be a simple abscess and it's not continuing to get bigger and their symptoms aren't continuing to get worse, then I would, obviously you're going to consult an orthopedist, but just start them on IV antibiotics, consult your orthopedist, and he may just say, hospitalize them, watch them for the next 2 to 3 days. If they continue to improve instead of get worse, then it's okay to send you home with PO antibiotics, and that is appropriate. Don't be scared. Chronic osteomyelitis, again, timing. So chronic is going to be greater than 6 weeks. You've got infected dead bone within the compromised soft tissue that is just encased. It can become very sclerotic or hardened, so they're going to probably have a bone nodule that you can palpate. It's avascular because they've got so much calcification embedded in there that it's walled off. And then sometimes the muscle itself gets scarred down because it's so much calcification being embedded. This is when you have an area that sinus tracts do not occur. That's why it's not draining and not disrupting the outer cortical bone. It's just all well encased within. Again, definitive diagnosis would be with the biopsy. Actually getting within the necrotic tissue itself and biopsying that tissue. Here's your chronic osteomyelitis classifications. So knowing whether it's just in the medulla of the bone, medullary. Superficial, that it's just on the cortical outside, not infecting the medulla. Localized is actually both, but just on one area. And then diffuse is throughout, just completely destroying the bone. Osteoma. So that tells you what the classification, 1, 2, 3, and 4, and then typically what you would do as far as treatment. This is the most common presentation of what your host is going to be like according to your chronic osteomyelitis. So if you have good localized vascularity, your patient is usually going to have normal physiological type. If they have local or systemic factors that are compromising their immunity or healing, then it's called host compromised. If it's been there long enough or they are just not responding at all, it is either disabled or prohibiting, causing morbidity, and a poor prognosis for cure is your post-prohibited. Again, those are just physiological types of your patients with chronic osteomyelitis, giving you prognoses. This is for an orthopedist to know. I won't be testing one physiological type. All right. So the main thing is going to be your timing, and then your physical examination. Where is it involving? Is it involving the bone medulla, the bone and the soft tissue, completely obliterating the bone, or just localized? Pyogenic, non-pyogenic, and then the presence of a sinus tract is going to help you know whether or not it is acute, subacute, or chronic. We've already talked about these lab orders. It's on there again. Most common, Staph aureus again. X-rays, just know the timing. It doesn't show up immediately. How many days does it take to start showing up on X-ray? 10 to 12 days. Cortical destruction, periosteal reaction, and then the sequestration. Scintigraphy is that nuclear medicine scan. Sorry, I didn't explain that on this. This is a messed up, horrible chronic osteomyelitis. So I actually have had a patient with gunshot wound that had been treated for years for his chronic osteomyelitis. Otherwise, he was healthy. Shot in the calf. I don't know. He did it himself by hunting accident or what. I didn't ask him. Didn't matter. But he constantly had a sequestration and it would drain. He never really got septic over it. He would know when he needed to go ahead and get on antibiotics or when to just leave it alone. But it was ugly looking and smelling always. He was like in his 20s. So you can live with it because it walls it off, but it's nasty. Obviously, greatly deformed. There goes one more. All right. This is just telling you more about the imaging with the scans, isotopic versus non-isotopic. When you're talking about ionization, ionization indicates whether or not it's destroying the cells, and those are the radiations that's bad. So like your CT, but your scintigraphy, which is just a non-ionizing, is not really destroying the cells. I don't know if it has to do with the power of radiation or what. Gallium is the type of marker that helps increase the uptake, so it's the contrast goes to the area where inflammation, so leukocytes and bacteria accumulate. That's why it shows up and lights up on scan. CT scanning is good for identifying a sequestration because that really focuses on bone itself, not just bone and soft tissue. So if you're looking at the bone, trying to determine what's going on within the bone, that's the CT that you want. MRI, again, soft tissue and bone. So just know that if we're looking for both, like discitis or the soft tissues surrounding the spinal cord, that's the MRI that you're going to want. You don't need to know surgical treatments. These are other different types of surgical, plastic surgery, as well as other ancillary hyperbaric chamber for treatment, wound dressing. No big deal. You don't need to know all that. And again, so the antibiotic treatment for chronic osteomyelitis, when they've got a flare-up, it'd be a 6 weeks of antibiotics, IV. So when you've got somebody that's been on IV antibiotics for a long period of time, they may end up getting an organism that's more resistant. The rest of this, again, is for specialists, because you're not going to need to know when to amputate and when not. So diabetic foot ulcers, that's why it's really important that you get them treated, because that's when they start losing toes and feet and legs. Okay. Depends on the involvement of the joint of the actual osteomyelitis, determines how high up the amputation is going to go, obviously. And then sclerosing osteomyelitis of Gary. This is another one that they like to ask on your boards. So the descriptions here, bone is thickened and distended, but the abscess and sequestra are absent. Again, all of that other stuff as far as details, now you know what a sequestra is. We already know what an abscess is. The cause is unknown, and then again, it's thought that the etiology of low-grade, possibly anaerobic bacteria. So again, that's why when you do those biopsies, it's aerobic and anaerobic. Chronic osteomyelitis, see how that's scarred down? You no longer have a sequestrum or an abscess. There's no translucency or density change throughout. There's a hyperdensity due to the calcium deposit there. Okay. Tons of stuff.